My talk today is going to be focused on genetic counselling because I think we had two brilliant talks on genetics and a very good introduction to CNV. So I think it's really good. But I was talking a bit to Louise earlier. It can be quite intimidating to have in mind all the science and also feel the pressure that you need to translate all that science not just to yourself but also to patients in a way that's meaningful for their family. So I think genetic counselling can be very good at that. So I'm going to talk to you today about genetic counselling in general and genetic counselling for psychiatric conditions. And I'm going to try and give you just an example of a few techniques or metaphors or strategies that we can use in genetic counselling that can be very useful for families. And you don't have to be a genetic counsellor to use them. So maybe some of you will find it useful to just get a sense of one of the things we're doing. So this is what I'm going to try to do, but please stop me and ask me questions if you want me to detail a few things a bit further. So I don't think there are many genetic counsellors in the room, so I thought it might be useful to start with the definition and just to see where we're at the moment or what's our rationale when we see patients. So genetic counselling is pretty much the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So this is the definition that has been around for decades and is very much contemporary, I think. We all use it for many, many years now. But I think the key words in this definition is both understand and adapt. So it's crucial for patients to understand their condition, their risk, their options, the genetic contributions, because there's not always a genetic cause for the condition they have. So understand all of that, but also adapt to it, because understanding doesn't always mean adapting. So adapting to both the medical, but also the psychological and the familial implications of all the information they receive. So this is what we're doing, I think, when we see patients and families or members of the community. So over the last few decades, the goals of genetic counselling have been pretty much the same. They have been evolving a bit, but I think to a very great extent, genetic counselling has psychological and educational objectives. So we try to explain and promote patient understanding. We try to maximize their options, promote health behaviors, but also facilitate coping in patients and in families, improve their well-being, facilitate their adaptation, help them reduce their emotional distress, help them make decisions, informed decisions, improve their self-efficacy, and pretty much facilitate their strength and help them use their resilience in adapting, I suppose, to risk, testing, diagnosis, and living with various conditions. So I think if you have these goals in mind, in terms of what genetic counselling means, you have a pretty good understanding of what we do on a daily basis. So I think what probably most of you know or imagine when they hear genetic counselling is some like family trees like that, perhaps, or family trees where you would see perhaps a few, I don't know, patients or individuals affected with cancer or at risk of. So this is something I think we all got really used to over the last few decades. And I think initially genetic counselling was pretty much set up and used for families that were impacted by single gene disorders or conditions where genetic testing for susceptibilities, such as for example, cardiomyopathies or breast and ovarian cancer, were available. So this is what we have been doing, I think, for the last five decades, and we have been doing that quite a lot. So I think this is the prototype of genetic counselling that everyone is most familiar with. But before I get into more details, I thought it might be useful just to have a sense of what a session looks like, just in case some of you never sat in or really spoke to a genetic counsellor before, if that's useful. So would it be useful? Okay. So a genetic counselling session, and it's usually a one-off. So usually we see patients once every now and again, we see them 2 times or 3 times perhaps, especially if we're talking about pre-symptomatic testing or testing for someone and then giving them the results or following them up. But usually genetic counselling happens in 1 session, and we have to be quite mindful of time, I think, because we have to make sure we cover all of this in 1 hour, sometimes 50 minutes, and depending on the clinics you're in, even 40. So we always start by making sure that we understand the consultant's needs and concerns and exactly why they came to see us, and if there's something in particular they would want to discuss. And then we always talk about their personal and family history, and we took quite complicated pedigrees, as you saw earlier. And then we try and see if there are any risk for family members or someone else in the family that might be interested of or at risk of, or I don't know, having a test result for something. So we always cover that in the first few minutes of the session. And then we try and focus, and I'm going to refer you back to the definition. We're going to focus then on helping them understand and adapt to their question or their risk or their test or their condition. So we always talk about the disorder, the incidents, the causes, the symptoms, the inheritance, the record, everything that they need to know about that disorder. We talk about the treatment that's available, genetic testing, whether that's available or not, and the options for that, risk factors, trigger factors. And then we also discuss treatment, management, preventions, risk reduction strategies, pretty much everything. But always, we always have in mind the psychological support they have available or the psychological support they might need in order to live with that condition or live with that risk. And we always make sure we address issues such as anxiety and guilt and shame and stigma, because these are things that come up quite frequently in our clinics. And when they need to make decisions, we always try and help them make those decisions. And decisions can refer to whether I want to have a genetic test, as some of you already mentioned earlier, whether I want to opt for some screening options or prevention options, or whether I want to talk about my condition or my risk with the rest of the family, whether I want to, anything, reproductive decisions, of course. So any decisions that they might feel they need to make, this is all something we always talk about. So it's quite an intense session, and there are a few things we need to cover. And I'm very happy to say that genetic counselling has a very strong evidence base behind it. So even if it looks like a lot to do in 1 hour, and it looks quite and can be quite intense, there are many studies who say that what we're doing is quite good. So over the last 5-6 decades, you will find in the literature, if you want to know more about that, a number of opinion papers, case studies, research studies, systematic reviews, and even randomized controlled trials looking at various aspects of genetic counselling. Is it working? For what patients? For what conditions? Whether it's done with or without genetic testing and all of that. So there's massive research done behind or to investigate genetic counselling. And I'm only going to refer you to one paper, which is quite recent, it's a couple of years ago, and it's a systematic review of all the randomized controlled trials done in order to assess the outcomes of genetic counselling. So if you only read a paper or two, this is one of them. So I chose this because it's like one of the papers up there that summarizes pretty much all the research done previously. And that paper and many others have shown that consistently genetic counselling improves patient knowledge, empowerment in patients, risk perception. That means after genetic counselling, patients tend to have a better or a more accurate risk perception, just because, as you know, some of them will come and overestimate the risk of having something or sometimes underestimating it. Emotion regulation, autonomy in decision making, it decreases stigma, and patients and families are usually quite happy with genetic counselling. So I think it's very reassuring as a professional to know that what I'm doing actually works. So it really does work. Moving a step forward, and trying to get closer to psychiatric genetic counseling. I think in parallel to those studies, but not at the same speed, we have seen quite a bit of interest in psychiatric genetic counseling, because mental health professionals have said for quite a long time that mental health disorders run in families. So that aggregation pattern was seen and discussed by professionals, even if they weren't geneticists or anyone, like, even if they didn't have experience in this field. So they're gonna, if you want to see more research about this, there are quite a few really interesting papers in looking how genetic counseling was anticipated and I suppose mentioned indirectly by many professionals, saying that this seems like it runs in family. And then, just a side note, my background or my interest in genetic counseling pretty much came from clinics, like seeing patients with schizophrenia, with bipolar, with schizoaffective disorder that would ask me about their family history and trying to understand whether that has any impact on their condition or the risk for other family members. This is what actually got me interested in genetic counseling. So it was quite intuitive to begin with, but it started a whole new field, I suppose, in terms of what psychiatric genetic counseling is today. But basically, psychiatric genetic counseling is not anything different than genetic counseling. So the process is pretty much the same. And we have quite a bit of research showing that people are interested in psychiatric genetic counseling, and they're very positive as far as psychiatric genetic counseling is concerned. And quite a bit of data showing that genetic counseling is not dependent on genetic testing, because we know genetic testing for psychiatric conditions can be quite problematic. But I'll come back to that. So there are quite a few studies showing that psychiatric genetic counseling works. And I'm just going to show you a study that we did with Janine Austin. Some of you might know her or heard of her. So we tried to do a meta-analysis, again, a research trying to summarize all the previous research done in psychiatric genetic counseling. And we thought maybe there's enough to do a meta-analysis and get a sense of where we are at the moment. And again, the results are quite positive. So the effect size for the overall significance is 0.56, which in coincidence is not too bad. So psychiatric genetic counseling has a significant effect. We seem to have a similar effect size for family members and patients. So whether we see someone diagnosed with, I don't know, schizophrenia, for example, or a family member, genetic counseling seems to be as effective for both of them, which is quite good to know. And another really interesting result we had was that psychiatric genetic counseling works just as well when delivered by genetic counselors or non-genetic counselors, which is, again, quite empowering, I think, especially for people who are not trained as genetic counselors, but would like to do that for their patients. So there are two studies, I think, in the meta-analysis we included, where mental health professionals were trained in delivering that genetic counseling session. And they actually had very good results with both patients and family members. So that, again, was very encouraging. And results also show that although both knowledge improved after being part of a genetic counseling session, and the psychosocial variables also improved, there was a significant difference between the two. So that means genetic counseling works, but it seems to work a little better in terms of improving knowledge for patients. So that's one of the biggest benefits they have. So I suppose, as a quick summary, it's important to know that genetic counseling is beneficial for both family members and patients when delivered by both genetic counselors and other professionals, and all these gains are maintained at follow-up, which is also a very encouraging finding, we thought. So not only genetic counseling works, but now we know that psychiatric genetic counseling works. So having this background in mind, I thought it might be easier now to try and give you a few examples on something a bit more particular to the workshop today. So I'm going to try and zoom in a little. So if you try and think of the patients you see, whether they come with a genetic condition or a test result, and you stop and think for a few seconds if you can come up with what are the most common responses they have after, I don't know, CNV test results, what would you say those responses are?
Did I cause it?
Did I cause it?
What does this mean for me?
What does that mean for me?
Stuff like that.
Yeah, yeah. So I
Or
think
if there's no result, what does that mean?
yeah, yeah. There's no. So it's a number of things, isn't it? And I think some of the responses we have seen, and probably some of you too, can be something along the lines of disbelief. Like sometimes that you don't really feel that that particular result applies to you or your family. Distress can be quite often the case. Anxiety, confusion, burden, shame, guilt, reassurance seeking, and sometimes behaviors done in order to reassure the information they got. Relief sometimes, oh, that's what I have, now it makes sense. So any of these responses can be just as plausible, I suppose, and the impact these results have can very much depend on the nature of the condition, because obviously you need to factor that in when you get a result. Is there treatment available? Okay, so I got this result. What does that mean for me? Is there any treatment? Is there any screening? Is there anything at all I can do? Perceived burden of the condition. I suppose that could mean something like that can be shaped by the patient's previous experience with that condition, depending on who you met or who else in your family had that condition. That will shape pretty much your expectations and the burden you anticipate for that particular condition. And this is why everyone will be unique. The relationship that person has to the affected person. What's the family context? What's the timing? The extent to which they expected that diagnosis. And one other thing that always, I suppose, needs to be factored in is their resilience and coping and the way they previously adapted to stressful situation or ambiguity or unknown context or situations, really. So when we talk about CNVs, and I'll show you a few examples in a minute, it's quite complicated, or it can be. So when we talk about complex conditions or genetic testing or genetic results or interpretation, that's one aspect of it, I suppose, the complexity of the problem we're dealing with. And then we also have to factor in the science and the jargon that we have to use and then translate to someone. It's sometimes difficult for us to understand, let alone explain that in a way that people can actually understand and then just see how that applies to their life. It's hard to phrase things. It's hard to explain what uncertainty is and what that means for them. It's very hard to explain something when there's low or no prior knowledge on something. Again, you have to rephrase everything you know and then re-explain that and give more examples and more analogies and just try to make it more personal for the person in front of you. On top of that, you have to always take into account the personal circumstances in someone's life, whether there's, I don't know, a new couple or a new family or someone living with a condition or a concern for years now. Just like I think Lisa gave an example earlier, just living for 2 years with an information that you have to adapt to. And then you see that person and try to factor all that in your genetic counselling session. And then just explain all the possibilities, what it means, what it doesn't mean, what we know, what we don't know, what we don't know that we don't know, what the future is, and all of that. And again, have in mind the structure of the genetic counselling session and do that in a meaningful way in, say, 1 hour. It really can be challenging, not just for ourselves, but also for the patients, because it feels sometimes that they're just bombarded with information. And then you read websites and leaflets and speak with various professionals, and it's sometimes quite hard to absorb all of that, again, in a meaningful, personal way for you. So how much is enough? I think as professionals, we sometimes ask ourselves that, how much do you give? How much information is useful, and how is knowledge really power? I think this is another question we probably ask ourselves, or it might be interesting to get a sense of what you think. Is knowledge really power? And there's a bit of research on that as well. So it's a really, really interesting and open question, but I think I need to be aware of time, so I won't go into too many details. But it won't surprise you to know that there are quite a few barriers that we need to have in mind when we try to deliver all that information, all that context. And these are some of the barriers you probably know, and I kind of anticipated. But overall, I think the main challenge is balancing the science and the counselling, the understanding and the adapting. So what exactly do I need to know in order to actually adapt to that information or that risk or that test or that condition? So how do you find that balance? And I mentioned the research available, and it may not surprise you that most professionals think that if patients understand the scientific information, they will adapt to it, or its information will actually empower them and it will help them adapt. And it is true to some extent, but the research that we have from genetic counselling and a few other, I suppose, areas, is that it's just us, really. It's a projection, just because we're more comfortable to provide information. And I suppose it's easier to do. It doesn't mean that's the most beneficial thing for patients or families, because in fact what they say is that the most important and meaningful outcome that they get out of genetic counselling session is the psychosocial aspects of that particular session. So helping them or meeting their emotional needs and meeting their expectation and addressing their concerns is just as valuable, if not more valuable, than actually providing them with the scientific information that we think will give them more power, because sometimes it's just overwhelming. So again, going back to the balance we always have in mind, and this is a challenge for us as well in genetic counselling. And there's many papers out there helping us get a sense of how to best balance this. I suppose one way of looking at it, before I show you a few examples, is thinking of uncertainty. Is it always bad? And then how do we approach it, and how do we phrase things in a way that actually leaves room for hope? And it's easier said than done, isn't it? So I think quite a few things that have been done recently in psychiatric genetic counselling, and I'm going to show you a few examples of the things we do in clinics, are trying to do just that, help us have like a visual I don't know, image or something that we can use to prompt risk, but also options, and try to remind us of that balance, I suppose, of science and counselling that can hopefully go together. So I'm going to show you a few examples that Janine Austin has developed a few years ago, and this is something we use a lot with the psychiatric patients we see, and this is something we always find useful, I suppose, and families love it. I suppose it's a very good way of helping us make sure the patients get the gist of it, and just the essence of the message they need to take home. And if they want to talk more and know more details, of course we can provide that. But if we are to, I don't know, at the end of the session, make sure they have the basics of it and then just understand what that means for them, this is one way of doing it. And we can always explain that the jar gets full with both genetic factors and environmental factors. So that's the first step I think we can do. And then we can obviously explain what these genetic factors can be, and for example, where CNVs fit in, but also what are the environmental factors. And obviously for psychiatric conditions, you need a bit of both. So it's very hard to have a full jar and experience, for example, an active episode of illness, unless you have both the genetic vulnerability behind it, but also the stressful or the environmental factors that contribute to that. So it's very easy, for example, for everyone to understand that you are born with a genetic vulnerability. And we find it, again, quite useful to write on these yellow balls, if you like, some of the CNVs or some of the results they have, because they obviously contribute to that. And you're born with them. So you're born with the vulnerability to develop something. But in time, and due to I suppose the interaction between the genetic factors you already have and the interaction between the genetic factors and the environmental factors, you could end up developing a psychiatric condition. But again, this illustrates quite nicely, I think, that the psychiatric condition is developed by having both, not just environmental and not just genetic. Another graph that we tend to use, and again it's quite self-explanatory, is that the jar can get full with environmental factors and genetic contribution in different proportions. So that's also quite easy to understand. Our genetic vulnerability is not the same. We all have it. It's just not identical. So depending on the genetic vulnerability we have and the environmental factors we have throughout the life, we may end up having a psychiatric condition. Although the starting point is quite different, we might still very well end up in the exact same place. This is a slide we use to try and explain why different children may have a different genetic vulnerability, although they have the same parents. So I think it just speaks for itself, doesn't it? It's quite easy to get, I suppose, and see how that works for you or your family. But also, I think, if we're trying to think of a CNV or something where we have some genetic testing available, we can show that the CNV someone has, yet not everyone, can come from the mother, for example. But also why someone could have a CNV or could have something we can test for, yet it doesn't happen in anyone else in the family. So it just happened, and it's a very easy way to explain de novo mutations or de novo results. So again, something quite easy to explain. I think that this is a slide a graph we use to show that everyone has some genetic vulnerability. Some of us are low risk, some of us are moderate or high risk. And it's very hard to know where you are on that continuum because we can't test for everything right now. And I think it helps capture, I suppose, the complexity of the genetic testing, I suppose, because it's very, very hard to test for every genetic factor that might be involved in developing a psychiatric condition, but also it shows that everyone is, to some extent, vulnerable, more or less. We just can't really know in advance. We can show why some CNVs, for example, can be associated with a high risk, although that doesn't mean you're affected, but you are higher risk. And I'm talking here about high risk for mental disorders, not other syndromes. I hope that's quite clear. But also why the same CNV for example, referring to the talk you had earlier from Louise, can mean both high risk and moderate risk, because we don't really know always why some CNVs, for example, are associated with some symptoms and not others, or why some symptoms are a bit milder, I suppose, in some patients. So again, it's just this, I suppose, a small graph that we can use and show our patients, try and translate everything and put it into something quite easy to understand and take home. One other thing we use is we try to show patients that although they can be quite vulnerable, and some of us are born with the high vulnerability to develop a mental disorder, it doesn't mean that we will get it, because actually in time all the environmental factors, some of them we know and some of them we can protect ourselves against, and there's a bit of literature on that. And another thing that we use quite a lot, and this is something this is one of the slides that would help empower the patients, as I mentioned earlier. Even if you have an active episode of an illness, even if you have a condition, that doesn't mean that it can't get better. So some of the environmental factors can actually be removed. Not all of them, but some of them will be removed. And also there are a number of protective factors that we can use in order to make our jars a little bigger, our resilience, I suppose, a little bigger. So some of them can be, for example, treatments you get to medication is one of them. Healthy lives can be another one. Sleeping can be another one. Diet, and so on and so forth. So there are a number of things we can do, not just by removing environmental factors that put us at risk, but also by adding protective factors against the vulnerability we may have and the environmental factors we may not control. So this is just an example of things or graphs we use with patients all the time, and something that makes sense, I suppose, and things that are quite easy to adapt and personalize to every single one of them. Because obviously you can write on them or just explain what test results they might include, or what are the environmental factors we need to consider, and what are the particular protective factors that's specific for their family or their particular situation. So this is just, I suppose, a sense of some of the things we're doing. So just to sum up, because I'm quite aware of time, I think understanding, going back to the definition I showed you, understanding and adapting to risk, test results and diagnosis is complicated. And the most important things patients and families appreciate in genetic counseling session is the psychosocial aspects, although knowledge is essential unless that knowledge is translated in a way that patients can actually understand and absorb and adapt to. I suppose it's less meaningful for them. So genetic counseling can help do pretty much all of that. So I know there are quite a few genetic counselors in Ireland, and I think in most other countries. Perhaps this is something you can engage with if it's something that you can do easily, or if it's just psychiatric genetic counseling, there are quite a few workshops and trainings available, or courses that you can attend, and then just see how and if you can use some of the things that we already know are working for the patients or the families that you see. So I think I'm okay with time, but that's my email address. So if you need some of the things we do, or if some of the things we do might be useful for you, you can just drop me an email and I'll send you, what we have. So that's me for now, I think. Thank you.
Any questions for Ramona? Yes. Sorry, two questions actually. The first one, in the clinic, do you have an actual jar with the pebbles, or do you show pictures?
We usually show pictures. We don't have a jar.
Yeah,
but that's a good idea.
No,
I think
maybe for like a physical thing.
I suppose for kids that would be quite useful, or for someone,
Yes, but make it plastic.
Yeah.
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 And then I was wondering, for the genetic counselling, do you do it you said you did one session, and do you do before and after? Because I was wondering, because sometimes I've seen Janine talk, and she's guys are amazing, and she talks about the importance of genetic counselling before any genetic information is given as well. So is that what you do, one session? Is that after getting genetic information?
What do you mean by genetic
Or
information?
like before any genetic testing, sorry.
Well, the majority of the people we see do not do genetic testing.
Okay.
So that's why I asked earlier about adults, because for children that's quite not easy, but I suppose they're looked after by pediatricians and geneticists. Adults, I think, in our experience, is a bit trickier because they're not really seen by anyone. So they would have to go to their GP, and their GP would refer them to a psychiatrist, and if sometimes, rarely, to a geneticist, and that's all they get. So we usually don't have to deal with any genetic information. So they would just come with their personal history or family history, and then just ask questions like, I have schizophrenia, my cousin had, I don't know, OCD, is my child at risk? So you have to, without any other information, I suppose. So we usually see patients, rarely, mainly with children, I suppose, but rarely with genetic information. So we usually work with the psychiatrist that would refer the patients to us.
Can I ask a question?
Yeah.
So I'm just wondering, I like your statement, how do we provide counselling that leaves room for hope? And I'm thinking about a lot of the, families that I work with, if they get a genetic diagnosis, there's a huge amount of uncertainty because there's maybe very little knowledge about the condition. A lot of healthcare professionals don't know about their condition, or there are now so many CNV syndromes emerging that we as psychiatrists or pediatricians or healthcare professionals working in non-genetic settings may not have all the information. And I suppose even for genetic counsellors, there isn't the information really. So what do you think we need to be doing, to help families who are affected by genetic diagnoses where there maybe isn't a huge amount of information?
Let me go to a slide that might help my... I suppose one of the things we do is, and I'm backing this statement with some of the research we know, for example, from clinical psychology and health economics and all of that. And we know quite clearly that if you give the same information, but phrased in two different ways to two different, people randomized to two groups, they will make different decisions. So if you say you have 10% risk of getting this condition, is one way of phrasing it. But if you say you have a 90% chance of not getting it, it's a completely different phrasing, I suppose. And there are many decisions, like financial decisions. You have, I don't know, the opportunity to lose money if you bet, I don't know, £4. You bet £4, I think. You buy something with £4 and you have the opportunity to win something that is worth £10. And then you rephrase that with, I don't know, you bet £6 or something like that. And then you have the opportunity to win something that is worth £10. Which one do you choose? So it's quite obvious when you do it with simple things. But when you try to phrase that for complex conditions and complicated decisions, there's quite a bit of research showing that the phrasing actually frames the response. So one thing that we do is always present data in at least 2 or 3 ways. So for example, if there's a family history of psychiatric conditions, say schizophrenia, and I am at risk because, I don't know, I have 1 or 2 first-degree relatives with schizophrenia, for example, and I'm at risk of, I don't know, perhaps between 4 and 14 or 16% of developing schizophrenia myself, and that would be the empiric risk. You can always say that, but you can always say you have between 80 and 95% 8% chance of not doing it, and you need to compare that with the 1% lifetime risk, and that suddenly sounds a bit better. So this is just an example to show that even numbers can be presented in a way that is not scary, I suppose, and that just leaves room for hope. And then I think also we try to phrase the unknown into possibilities. So the fact that we don't know anything now can only mean that people are working on it. And I suppose in the next few years, there's hope for research or hope for better treatments or more accurate tests or any of that. And I think, yeah, we try to do that quite a lot. Phrase, yeah.
I think in the, oh, sorry, have we a question? I think maybe we'll, Alina, do you want to ask a question or do you want to?
Yes.
Okay, and we've one more question and then we probably do need, so go ahead, Alina.
Yes. In the Netherlands, there's this discussion going on that more and more medical specialists are ordering genetic tests directly from the laboratory, and these specialists might not have this tradition of offering genetic counseling.
Yeah.
Do you think that is a problem, or what do you think that we should do with that?
Yeah. I think it's a massive problem, and I think there are quite a few international guidelines saying that for some conditions you should never ever have tests without genetic counseling. But unfortunately, there are many private clinics and there are a few other ways of doing it, or do it abroad, for example, where that is still available. And there are many ethical debates on that because patients are not actually prepared to hear that result or hear that diagnosis because no one actually took the time to do that. And yeah. Yes, please.
My question is about how it's about how you do those or manage those sessions. So you said that in the jar you represent the SNPs or the
CNVs or
genetic loaded, like those, and then also you talk about environment factors that could affect these conditions. Did you ever take details of, let's say, like, of which factors could alter this condition? Like, I don't know, like if have problems at the birth, or any developmental problems, or you in the same way that you give examples of we identify this CNV. Yeah. And you also have this. You have been reported in your clinical history that you have problems at birth. Yeah. You put those examples also in environment factors that could affect. Absolutely, because
because they're not genetic, are they? Some of them are not, so you might just as well do that. So I think one of the things, I'm just a bit caught by surprise here. Sorry. That's fine, but I think the beauty of it, if you want, in using these jars, for example, is you can easily use them for any complex or multifactorial condition. So whether you want to talk about children or cancer, even if you want to talk about that, or mental disorders or anything that's multifactorial, it can be quite easily adapted, and you can then choose to adapt it yourself for your own clinic or the patients that you see. And for the patients I see, for example, it's quite easy, and I already have almost a routine of what I write on the jars and the graphs that I'm using. But other colleagues working in cancer, I don't really work in cancer, but many colleagues use these for cancer as well, because you can include the screening, for example, or the testing that you have, but also the hormonal factors or pregnancies or age of, first periods and first birth and breastfeeding and all of that could count as a environmental factor that you need to take into account when you calculate the risk. And then
And I have another question. You said that the improvement of the patient get an improvement in the knowledge of what is happening.
Yeah.
How do you know at the end of the session that the patient have understood everything that you have communicated them? Because sometimes you explain things
and they say and
they don't understand really what is how you control this part.
Well, when I say that,
if you control it, I don't know.
I can give you Yeah, do I still have time to do that? Because I think Ellen is not.
Yeah.
And I can show you more details, I suppose, in the break. But when I say genetic counselling improves knowledge, there are two ways of checking that. One of them is the randomized controlled trials that we have, where you would have a questionnaire before and after the session.
Okay.
So if you have that, it's quite easy to measure and compare that. And then on a case-by-case situation, I suppose it depends on your clinician, I suppose, abilities to just see, do you see what I mean? Like, could you please tell me how you would explain your husband what we discussed today? So there are a few ways of doing that individually, but when I presented that, I meant the randomized controlled trials assessments before and after the session.
Thank you.
Yeah, thank you.
That's really helpful. Thank you. Thanks very much, Ramona.
Thank you.